Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes, and this is another classic clinical presentation. If you like these types of videos, please like and subscribe to my YouTube channel. It will really help me. Okay, let's meet Jim Smoky Bueger. Meet Smoky Bueger. Smoky is a 75-year-old male with a past medical history of high cholesterol, grade 4 renal failure, lumbar stenosis, high blood pressure, and a TIA, who has been bothered by strange and severe leg pain. He is not a particularly active male, but he does walk his dog daily to the park at the end of his block. In the summer, he noticed that by the time he got to the park, he was really ready to sit down. He would let the dog run for a bit and then he would walk home. He has always been a little short of breath with walks, but this is different. Lately, he has not been able to go so far. If he walks to the park, he needs to stop at the bench in the middle of the block. If he tries to climb his stairs to the third floor, he simply can't make it. His calves start to burn and cramp up. Sometimes his thighs are also affected. He feels like his legs weigh 100 pounds each, and he absolutely must sit down. Once he sits down, the pain begins to subside, and after a while, goes away altogether. The weird thing is, he feels like he can almost set his clock by it. It's so predictable. He walks 4 houses or 1 flight of stairs, and he must sit down. He goes to the hospital and meets the doctor. Doc, I don't know what's going on with me. I have been having severe pain in my legs when I am walking the dog or walking upstairs. It can become incredibly intense and throbbing, and all I can do is sit down immediately. Once I sit down, it starts to ease off and then it goes away. But if I try to walk any distance, it comes back. I have smoked for a long time and I always got a little winded with activity, and it was a bit limiting, but this is much more intense. The doctor thinks, this sounds like claudication. He's an elderly vasculopath with lumbar stenosis. So, as yet, he's not absolutely sure of what's causing his claudication. He knows that there are 2 types of claudication, and he is at risk for both. Vascular claudication typically has cramping pain distally with activity, which is relieved by rest or standing. Worse when walking uphill. Pulses are decreased. The skin in the legs is shiny and hyperpigmented. Posture upright and normal. No back pain, no change with hyperextension of the back, and it's always related to exertion. Then there's neurogenic claudication, which is dull, aching pain, often proximal in the leg, relieved by leaning on a shopping cart. Better when walking uphill. People with neurogenic claudication have normal pulses with normal skin. Their posture is typically flexed because this is more comfortable for them. They typically have back pain, and their symptoms are worsened with hyperextension of the back. Neurogenic claudication is typically related to position. Our patient is a vasculopath with proven vascular disease. He's had previous cardiovascular disease and that he has had the heart attack and the stroke or TIA. He also has renal failure. Peripheral vascular disease would fit in well here. He also has high cholesterol. He doesn't know if he has atherosclerosis, but he does not have diabetes. The doctor does a full exam and decides to check his ABIs, or ankle brachial index. To accomplish this, he takes Smokey's blood pressure in his arm, 180/90, And then his ankle, 120/80. He divides the systolic from the leg over the systolic from the arm, and that turns out to be 0.667. Anything under zero point 0.9 suggests narrowing of the blood vessels in the leg. This confirms his suspicion that his issue is vascular claudication. But while checking his ankle pressure, he notices Smokey's legs. How long have your legs looked like this? Smokey says it seems like months, and that sore has been there for at least 6 weeks. Smokey's legs are shiny and hairless. He has increased pigmentation in the skin on the lower 1/3 of his shins, and there is an ulcer on his right leg. Peripheral arterial disease, or PAD. Not only is the blood supply compromised to the muscles, the skin, the hair, and the nails are also compromised. The skin becomes thin and shiny with minimal subcutaneous tissue. The nails are thickened. The skin may break down and form ulcers that do not heal. In the worst of circumstances, gangrene may develop on the pads of the foot and the toes. Usually, the immune system can ward off infection, but some situations make the infection more likely to win out over the immune system. These situations include excess sugar in the blood, because bacteria love sugar and they multiply quickly. A limited blood flow keeps the tissue from getting oxygen and makes it vulnerable. It also keeps the immune system and all its components from getting to the site. You could also have the domination of infection when you have crush injuries with damaged tissue, or if you're on immunosuppressive therapy or have an immunosuppressive disease. The blood vessel obstruction is typically caused by thrombosis. The thrombosis is most commonly the result of atherosclerosis. Atherosclerosis begins with damage to the arterial endothelium. It is damaged by high blood pressure, high circulating LDLs or low density lipoproteins, and smoking. The most commonly affected vessels include the carotid, coronary, aorta, and popliteal arteries. Low density lipoproteins pass through the damaged endothelium and accumulate in the intima. LDLs are oxidized into lipids. This triggers inflammation, and macrophages accumulate and create a lipid core with a fibrous cap. This atheroma is a lipid-filled plaque. When it impinges on the vessel lumen, it is called an atherosclerotic plaque, which is susceptible to injury and clot formation. What we're dealing with here is a situation where the tissue demand is greater than the blood supply. With claudication, you'll get symptoms that occur with increased activity because the muscles will need more oxygen. And the blood supply is fixed and limited. So the increased demand is not met and painful ischemia occurs. It resolves when activity stops and the blood supply again becomes adequate. One step further is chronic limb ischemia. This is when the atherosclerotic plaques impede normal blood flow significantly. This causes ischemic and chronic pain. They are even present at rest, but they still worsen if the patient tries to be active. Sometimes dangling the feet off the side of the bed gives the blood flow some gravitational assistance and makes them feel a lot better. Acute limb ischemia. This results when an atherosclerotic plaque is damaged and a clot forms, completely occluding the vessel. These patients have acute and horrible unrelenting pain and a cold extremity. Symptoms include pain, pallor, paralysis, and pulselessness. This is a true vascular emergency. This picture shows the clot forming on the atherosclerotic plaque and completely occluding the vessel. Smoky's blood tests are significant for an elevated B1 and creatinine. This was known. We knew he had renal disease. The rest of his laboratory studies, his EKG, and his chest x-ray do not contribute anything else to our story. So what now? Well, what needs to be done is you need to open the vessels. This can be done by surgical bypass of the vessel, past the atherosclerotic plaques, or you can do less invasive endovascular dilation and stenting. These are both possibilities. In order to do this, you'll need to find the blockages. An angiogram can delineate the anatomy and find the blockages. But you need to consult your vascular surgeon so you get the exact test that they need. If you're going to risk further kidney damage by giving the patient IV dye, you better get the right test. You don't want to do it twice. The information you get from this angiogram will determine if the patient's situation is amenable to a less invasive endovascular approach or if bypass is necessary. Medical treatment includes aspirin to thwart clotting. We don't want to convert his claudication into an actual acute limb ischemia situation. You also want to give the patient statins to reduce cholesterol and antihypertensive medications. And undoubtedly, he's going to need to stop smoking because smoking makes this acutely worse. Is this an emergency? No. It is urgent as the symptoms are progressing, but not an emergency. Critical stenosis or chronic limb ischemia with rest pain needs to be addressed promptly. Acute limb ischemia is a true vascular emergency that needs to be addressed immediately to save the limb. Don't forget the symptoms: severe pain, pallor, paralysis, and pulselessness. Here's a mnemonic to help you remember the risk factors for atherosclerotic disease. It's SAD CHF. Smoking, advanced age, diabetes, cholesterol, hypertension, and family history. Here is Smoky. He has been admitted to vascular surgery, and they will complete his workup and get his platelets and cholesterol under control and help him to stop smoking. Thank you so much for learning with me today. I hope you liked these classic clinical presentations. Check out www.medicaleducationinminutes.com. The medical decision-making course is a perfect companion to these classic clinical presentations. And the prices have been slashed for Black Friday. Okay, see you next time.